Hey everyone, if you're a pharmacist, you know GERD is something we deal with pretty much every single day, right? It's one of the top complaints we hear. So think of this as your practical toolkit for really nailing those counseling sessions at the counter. Let's jump right in.
Okay, picture this. You've been there, I've been there. A patient walks up and asks for, you guessed it, the purple pill. That's our signal, right? Our cue to pause. Because before we even think about grabbing that box, our real job kicks in. That's assessment. That one simple request has to be the start of a much bigger conversation, where we figure out if self-care is even the right move for them.
So, here's how we're going to break it down. We'll basically follow the flow of a real consultation. We'll start with patient assessment, then cover those critical red flags. From there, we'll talk lifestyle changes, the medication ladder, do a deep dive into PPIs, and wrap up with a quick look at special populations. Pretty straightforward.
All right, first up, patient assessment. This is where we put on our detective hats right there at the counter. We've got to get the story straight. Is this just some occasional heartburn, or are we looking at something more serious? Because you know as well as I do, the right recommendation always starts with asking the right questions.
So what are we digging for? It really boils down to frequency, severity, and timing. Ask things like, how many times a week is this happening? Or does it ever wake you up at night? That last one's a big one. See, if it's happening a lot, keeping them up at night or just messing with their daily life, that's our signal to take things a lot more seriously and start screening for those red flags.
Okay, let's talk about red flags. And honestly, this might be the most critical part of our job in this scenario. We are the gatekeepers. We have to know when to say, hold on, self-treatment is not the answer here. Spotting these alarm features isn't just a good idea, it's non-negotiable. If you see one, it's an immediate referral to a physician. No exceptions.
So you really need to have these alarm features burned into your brain. They're all serious, but if a patient mentions dysphagia, trouble swallowing, or that their symptoms aren't getting better even with the best PPI therapy, bells should be going off. Any single one of these could mean something much bigger is happening under the surface. Our job in that moment is simple. Stop what you're doing and refer them out.
All right, so once we've done our due diligence and ruled out any scary red flags, where do we go next? Straight to lifestyle. This is always where our counseling should start. Think of it as the foundation of everything else. For a lot of patients, these simple changes can bring huge relief, sometimes without even needing medication. And here are the big six, the essentials. When you're counseling, try to be super specific. For instance, instead of just saying elevate your head, tell them to put blocks under the legs of their bed, because just piling up pillows can actually make it worse. The beauty of these 6 points is that they are simple, they're actionable, and a patient can literally start doing them tonight.
Okay, so lifestyle's covered. Now let's talk meds. The best way to think about this is like a ladder. We're not trying to jump straight to the top. The goal is to start on the lowest possible rung that's still going to get the job done, based on how bad their symptoms are.
This table really lays it out perfectly. You've got your antacids and alginates down at the bottom rung. They're great for quick, temporary relief, but that's about it. Then you step up to H2 receptor antagonists, a bit more oomph, but the top of the ladder, that's the PPIs. And here's the key difference. They don't just relieve symptoms, they actually heal the esophagus. That's why they're the gold standard when things get moderate to severe.
And this brings up a super important counseling point about H2Rs. Their superpower is speed. They work fast. This makes them absolutely perfect for that on-demand patient, right? The person who only gets heartburn every now and then and just wants fast relief. It's a totally different ballgame from PPIs, which are slower to kick in and are really designed for that steady, day in, day out acid control.
All right, let's zoom in and do a real deep dive on PPIs. These are, without a doubt, our heavy hitters. They're the most powerful tool in the arsenal. But because they're used so much, we have to be experts on the whole life cycle. Not just starting them, but also understanding the risks, and maybe most importantly, knowing how and when to stop them. First, let's just acknowledge how good they are at what they do. When it comes to actually healing the damage in the esophagus, nothing beats a PPI. They're the gold standard for a reason. We're talking about healing rates that are literally double what you'd get with an H2RA. For anyone with more serious disease, that's a game changer.
And check this out, up to 90%. That number really says it all, doesn't it? A 90% healing rate for esophagitis in just 12 weeks on standard therapy, that's incredible. And that's exactly why PPIs are so crucial for healing that damage and stopping more serious problems down the road, in the right patient. But And this is a big but. With long-term use, we absolutely have to talk about the risks. It's important to frame this correctly for patients. A lot of these are associations, not necessarily a direct cause and effect, but they need to know the whole story. We're talking about things like an increased risk of C. diff, potential issues with bone fractures. It's all about giving them the full picture so they can make an informed choice.
Which leads us right into the super important topic of deprescribing. The guidelines on this are crystal clear. If a patient's been on a PPI for at least a month and their symptoms are gone, we shouldn't just be hitting refill on autopilot forever. Our job is to be proactive and actively look for a chance to taper them down or even stop the medication altogether.
So how do we actually do it safely? Well, here's the playbook. The number one rule is you never, ever stop cold turkey. You're just asking for that nasty rebound acidity. The key is to taper. You go step by step. First, maybe reduce from twice a day to once a day. Then you lower the dose, and from there, you can try moving to on-demand use or even switching them over to an H2RA for any breakthrough symptoms.
Okay, let's wrap up with a really common scenario we all face: GERD during pregnancy and breastfeeding. Here, as you know, safety is everything. Luckily, we have a very clear step-by-step approach we can follow.
It's basically another ladder, but this one is all about prioritizing safety. You start at the bottom with lifestyle changes. Step 2 is adding non-systemic stuff like your basic antacids or alginates. If that's not cutting it, you can move up to H2RAs. And only at the very top, for those really tough cases, do we consider PPIs, and only when it's clear the benefit is worth any potential risk.
So, to tie this all together, let's think of it as a simple 5-point checklist for every GERD patient. 1. Assess their symptoms. 2. Screen for those red flags. 3. Advise on lifestyle first. 4. Recommend the right med for the right severity. And 5, and this is a big one, reevaluate. At least once a year, ask, do they still need to be on this long-term PPI?
And that really leaves us with the big, final question we should be asking ourselves every day. Are my patients on the lowest effective dose for the shortest possible time? As the medication experts, that conversation starts with us. That push to optimize therapy, to deprescribe when it's right, and to make care truly personal for each patient, well, that's on us. That's our role to play.